Welcome to another PrecisCa tumor board. We've got a great number of cases to discuss today, a lot of interesting and challenging cases. Before we get started, I would just like to go around the chat room here and introduce anyone. I'm Ben Levy. I'm a thoracic medical oncologist from Johns Hopkins School of Medicine, and I'm joined today by a wonderful faculty, multidisciplinary faculty. I'll start with Dr. Kamage. Dr. Kamage.
Hi, I'm Ross Kamage. I'm a medical oncologist. I'm the director of thoracic oncology at the University of Colorado.
Great. Dr. Ginsberg.
Hi, I'm Michelle Ginsberg. I'm director of cardiothoracic imaging and vice chair for education at Memorial Sloan Kettering Cancer Center, and also professor of radiology at Weill Cornell Medical College.
Great. Dr. Force.
Hi, I'm Seth Force. I'm the chief of thoracic surgery at Emory University Hospital in Atlanta, Georgia.
And last but not least, Dr. Curran.
Hi, Wally Curran. I'm the Chief Medical Officer globally for Genesis Care and adjunct professor at Emory University.
Great. Welcome, everyone. Pleasure to have you all here. 50-year-old female, never smoker, diagnosed in 2019 with what was at that point stage 3 left lung adenocarcinoma. It was EGFR positive. The patient receives 3 cycles of neoadjuvant carboplatin pemetrexed, followed by preoperative radiation to the mediastinum and the left hemithorax to a dose of 45 gray and 25 fractions, then goes on to receive a right pneumonectomy and left mediastinal nodule dissection. The final stage is a YPT3 into M0. Now with a peripheral upper lung nodule 4 by 3 centimeters, currently not on any targeted or immunotherapies. I don't know the time elapsed between the surgery and the recurrence in the contralateral lung. Let's say it's 6 months. How would you manage this patient? We don't have imaging. We don't know a lot about the patient. I'll start with Dr. Curran. We have a left upper lobe recurrence, maybe 6 months, 12 months after surgery. Is this something that you would consider radiating? Would you default to the medical oncologist to make the decision first on targeted therapy? How would you approach this?
Yeah, I'd like to know histology first. Is this new histology? Is it the same histology? So that might influence the selection of systemic therapy and the involvement. I would be comfortable with a systemic approach followed by consolidation, SBRT, if this truly was the only lesion.
Dr. Kamage, your thoughts? You would want a biopsy first, or would you want moleculars on the new biopsy, or would you trust what was in the original sample to make your treatment decision?
Well, actually, the thing that went through my mind is this is a 4-centimeter lesion. And so did it suddenly appear out of the blue? In which case I'd be thinking that there's a completely different process going on, such as an organizing pneumonia, or had they actually been going through surveillance and there was something they'd been watching? So I think there's a little bit of the devil in the details here.
Let's assume that this is a new lesion, and I'll say it popped up 2 years afterwards. Would you start with osimertinib? Would you want another biopsy?
I mean, if literally they had been close observation and it went from nothing to 4 centimeters, I would want a biopsy.
Okay. And if it were positive for adenocarcinoma, consistent with an EGFR exon 19 mutation, would you feel comfortable starting osimertinib for this type of local, or I don't know if you want to consider this local or metastatic recurrence, given that it's a contralateral lung lesion after a left lung, I just want to see a right pneumonectomy, right? So is there?
I think that's incorrect, and I think it was probably a left pneumonectomy because they had a left lung cancer and a left mediastinal lymph node dissection. I think the right pneumonectomy is incorrect.
Yeah, but the left lung nodule doesn't make sense if it's a left pneumonectomy.
Well, they were diagnosed with stage 3 left upper lobe lung cancer and got neoadjuvant treatment, followed by, I would assume, a left pneumonectomy and a left mediastinal lymph node dissection, and now has a new. I don't know how you do a left mediastinal lymph node dissection with a right pneumonectomy. That would be, that's a new one on me. I might have to try to learn that.
I defer to the surgeon.
Let's say it's a left pneumonectomy with a right lung nodule, and let's say it's biopsied and again, it's adenocarcinoma. Would you want to give osimertinib in this case, Dr. Kamage?
So So the great thing is having a biopsy, we can confirm it's a recurrence because we'll be able to confirm the actual molecular information, not just about its sensitivity, but we'll be able to, look at its etiology. It'll hopefully have the same mutation that we had before. So technically, this would now be an oligometastatic situation. I think, the question is, was this the one that got away and therefore we could have a shot at re-curing, or are we worried the other shoe is about to drop and therefore we should start systemic therapy? I think that's a conversation to have with the patient. I would be totally fine with starting with the tyrosine kinase inhibitor, such as osimertinib, and then having Dr. Curran on standby to consolidate if there's still some residual activity.
And I think I already know the answer to this question, Dr. Force. Assuming this patient had a pneumonectomy and then had contralateral recurrence in an upper lobe, is there a role for surgery, a wedge, or any sort of operation, given that the patient's already had a prior complete removal of the lung with contralateral lung?
So, I mean, the short answer is maybe. I've done that, less than a handful number of times because it's obviously difficult. You can't do a lobectomy. You really can't leave a patient with only 1 or 2 lobes left. That does not work well. And in addition, it's a very complicated operation because you can't do isolated, you can't isolate the lung. You either have to do it with the lung still inflating in your face or put the patient on some type of extracorporeal bypass, so you can deflate the lung. So that's really like pushing it. So when I've done it is when you can do intermittent apnea with the patient and do a wedge resection. It's kind of hard to wedge out a 4-centimeter lung nodule, but for smaller nodules, definitely I've probably done 3 or 4 of those over, the 18 years I've been here. They don't present that commonly. So it would have to be a peripheral smaller lesion, but you can do it.
Okay. So yeah, we'll all have to use our imagination on this case. Let's say the patient does have a pneumonectomy. I'm not going to choose sides here, but has a pneumonectomy and then has a contralateral recurrence in the upper lobe of the contralateral lung. It's 4 centimeters. It's EGFR positive. We give some sort of TKI. Dr. Curran, final thoughts on decision-making about consolidated radiation and what dose you would use, and would that depend on the size of it, the location? How do you make a decision there? Let's say it goes from 4 centimeters to 2 centimeters over 8 to 12 weeks. How do you make a decision on radiation in those settings?
So the primary consideration, Dr. Levy, is normal tissue constraints around it. If we're talking about a peripheral lesion, upper lobe lesion, you can probably give in an unirradiated space, you could give the 18 gray times 3 I talked about earlier and really be an ablative dose. You may not need that much because of prior radiation we heard about this patient. Perhaps we dose reduced to 12 times 3, but I think we could give an ablative dose if it's only 2 centimeters.
Great. All right, so thanks for all the input on this case. I know it does require us to use some imaginative reasoning here, given that we don't know the full story. I try to summarize this in that if there was indeed a contralateral recurrence in the upper lobe of the contralateral lung, and the patient did have an EGFR mutation, depending on the timing of when that contralateral recurrence occurred, there could be a consideration to use targeted therapy followed by a consolidated approach, 18 gray and 3 fractions, ablative dose. There could be a role for a surgery in this case, but probably unlikely given the other options that exist on the table.